Hello, this presentation will be on drugs for asthma and chronic obstructive pulmonary disease, part 1. So what is asthma? Asthma is a chronic inflammatory disorder of the airway. It's characterized by a sense of breathlessness, tightening of the chest, wheezing, dyspnea, and cough. Its cause is an immune-mediated airway inflammation. So you have the inflammation, which causes the airway narrowing to occur. The pathophysiology, symptoms of asthma result from a combination of inflammation and bronchoconstriction. So treatment must address both of these components. COPD, or chronic obstructive pulmonary disease, is a chronic, progressive, largely irreversible disorder characterized by airflow restrictions and inflammation. Characteristics include chronic cough, excessive sputum production, wheezing, dyspnea, and poor exercise tolerance, and the cause is smoking cigarettes. The pathophysiology for COPD results largely from two pathologic processes, chronic bronchitis and emphysema. Both processes are caused by an exaggerated inflammatory reaction to cigarette smoke. So sadly, if patients don't smoke, if a person doesn't smoke, they would not develop COPD. They can certainly have asthma, but not COPD. Chronic bronchitis, which is defined by a chronic cough and excessive sputum production, results from the hypertrophy of mucus secreting glands in the epithelium of the larger airways of the lungs. Emphysema is the enlargement of the air space within the bronchioles and alveoli, brought on by the deterioration of the walls of these spaces. Among individuals with COPD, the relative contribution of these two processes can vary. So what are the drugs that are used for asthma and COPD? The two main pharmacologic classes are the anti-inflammatory agents, such as the glucocorticoids, prednisone is an example, and the bronchodilators, the beta-2 agonists, such as albuterol. Inhalation drug therapy is used for both of these, and there are three obvious advantages. The therapeutic effects are enhanced because the medication is delivered directly to where it's needed in the lungs. Systemic effects are minimized because, again, it goes directly to the lungs, even though you may have some effects to, say, heart rate because they're not cardioselective necessarily, and there's relief of acute attacks is rapid, again, because it goes directly to the lungs. There are three major types. You have the metered dose inhalers, such as your albuterol. You have respimats. You have the dry powder inhalers. And you have your nebulizer machines. Anti-inflammatory drugs are the foundation of asthma therapy and are taken daily for long-term control. So once a patient is usually past the mild asthma and becomes more of a moderate classification, providing the steroid use for those patients can be very helpful, very effective, and really improve their quality of life. The principal anti-inflammatory drugs are the glucocorticoids, such as budesonide and fluticasone are examples of these. Mechanism of action is considered the most effective anti-asthma drug available. They decrease the synthesis and release of inflammatory mediators. They reduce infiltration and activity of the inflammatory cells. They decrease edema in the airway mucosa caused by the beta-2 agonists. And they are administered by inhalation, but can also be given orally and IV if necessary. So again, their mechanism of action is to suppress inflammation. They reduce bronchial hyperreactivity and decrease airway mucus production. And they may increase the number of bronchial beta 2 receptors and their responsiveness to beta 2 agonists. They are used prophylaxis in chronic asthma. Dosing must be on a fixed schedule, not as needed or PRN, and they are not used to abort an ongoing attack because the beneficial effects develop slowly. The inhaled use is the first line therapy and management. Most patients with persistent asthma should use these drugs daily, and inhaled glucocorticoids are very effective and much safer than the systemic glucocorticoids. For oral use, patients with moderate to severe persistent asthma or for the management of acute exacerbations of asthma or COPD, they can be used. There is potential for toxicity. Should be used only when symptoms cannot be controlled with safer medications, such as the inhaled form of a glucocorticoid or an inhaled beta 2 agonist. Treatment should be as brief as possible. So many times we will only give them for a course of maybe 3 to 5 days. The shorter course also allows us not to have to titrate the dose down when we're done, and that is an advantage for the patient. Adverse effects of inhaled forms include adrenal suppression, oral pharyngeal candidiasis, and dysphonia. Glucocorticoids can slow growth in children and adolescents. However, these drugs do not decrease adult height. So what that means is it slows the growth, but the children usually catch up as adults if um, they are used as they're supposed to. Um, they, there's promotion of bone loss, which has to be watched, increased risk of cataracts, and increased risk of glaucoma. So regular eye exams are very important with patients that use these on a long-term basis. Their adverse effects of the oral forms are definitely much less with the short-term therapy, more severe with long-term therapy. There can also, besides their adrenal suppression, be osteoporosis, hyperglycemia, so you must be careful in patients with diabetes. There can be peptic ulcer disease, so you may need the patient to take these with food to decrease that. And again, in young children, you have the growth suppression. When you're going to discontinue treatment, it must be done slowly. Recovery of the adrenocortical function can take several months after long-term therapy. Um, Doses of exogenous sources must be reduced gradually, and during this time, patients, including those switched to inhaled glucocorticoids, must be given supplemental oral at times of severe stress. Next, we'll look at the leukotriene modifiers, and these suppress the effects of leukotrienes, and leukotrienes promote smooth muscle constriction, blood vessel permeability, inflammatory responses through the direct action and recruitment of eosinophils and other inflammatory cells. In patients with asthma, leukotriene modifiers can reduce um, bronchoconstriction and inflammatory responses such as edema and mucus secretions. They are considered a second-line agent. They are generally well tolerated but can cause adverse neuropsychiatric effects including depression, suicidal thinking, and suicidal behavior. So these must be assessed on the visits to the office, and you should let patients know about these potential side effects so that they can seek help if needed. The available agents include Zyflo, Accolade, and Singular. Another anti-inflammatory drug is cromolyn. It is used for prophylaxis only and not for quick relief. It suppresses inflammation and is not a bronchodilator. But cromolyn is used many times for children to help with their ability to participate in physical activity. So what cromolyn does is stabilizes the cytoplasmic membranes of the mast cells, thereby preventing release of histamine and other mediators. In addition, inhibits eosinophils, macrophages, and other inflammatory cells. It is given via a nebulizer, but it also is available as an MDI. Um, it is used for chronic asthma, for exercise-induced bronchospasms, and allergic rhinitis. Adverse reactions is the safest of any of the medications, but it can cause a cough or bronchospasm. The next is a monoclonal antibody, Zolar. Its mechanism of action is an antagonism of the immunoglobulin IgE. It's used for patients 12 years and older with moderate to severe asthma that is allergy related and cannot be controlled with an inhaled glucocorticoid. Adverse effects include injection site reactions, viral infections, upper respiratory infections, sinusitis, headache, pharyngitis, cardiovascular events, malignancy, and life-threatening anaphylaxis. And next we have the bronchodilators, which provide symptomatic relief but do not alter the underlying disease process, which is that inflammation. In most cases, patients taking a bronchodilator should also be taking a glucocorticoid for long-term suppression of inflammation. And the principal bronchodilators are the beta-2 adrenergic agonists. And that is the end of part one of this presentation.